Hi, everyone. Thank you all for joining LHSC's February Community Update meeting. My name is Deborah Wiseman. I'm LHSC's Corporate Nurse Executive and VP for the Emergency Services, Critical Care, Clinical Neurological Sciences, Medicine, and Nursing Practice. I'm so pleased to be hosting today's meeting and sharing updates on the important work happening across our organization. First, I'm going to just begin with our land acknowledgement. Today, our virtual community update meeting is delivered from Victoria University and Children's Hospitals, which are situated on the traditional territories of the Anishinaabe, Haudenosaunee, Lenapewauk, and Chinungtan nations. These lands are connected with the London Township and Sombra Treaties of 1796 and the Dish with One Spoon Covenant Wampum. We acknowledge our neighboring sovereign Indigenous communities, the Chippewas Thames First Nation, the Oneida Nation of the Thames, and the Munsee Delaware Nation. As many marked special February events that bring family and friends and community together, including Valentine's Day and Family Day, I wanted to highlight that marches also unfolded across Canada as First Nation, Inuit, Métis people, as well as allies come together to address the profound issue of missing and murdered Indigenous women, girls, and Two-Spirit Plus individuals. London's community gathered this past Friday for the Women's Memorial March. It was a walk down Dundas Street with a pause for a moment of reflection, unity, resilience, and a ceremonial round dance. For Indigenous communities, these marches represent a collective commitment to uplift families affected by this crisis and a poignant expression of remembrance and solidarity, serving as a testament to the resilience and love within the Indigenous communities. For LHSC, we recognize that Indigenous women, girls, and Two-Spirit Plus individuals do face disparity in healthcare access, and the work continues as we challenge our colonialized systems to create safer, more inclusive healthcare spaces grounded in dignity, accountability, and trust. As we continue our journey towards truth and reconciliation, we remain committed to listening, learning, and working alongside Indigenous peoples to advance health, safety, and well-being for present and future generations. These meetings are an important opportunity to share what's happening across LHSC and to celebrate the work of our teams and the impact they have on our families, communities, and our patients. As always, these meetings are live streamed through YouTube and a recording is made available afterwards. Our meetings also replay on Rogers TV London. Each month, we highlight examples of how our staff, professional staff, leaders, learners, volunteers, and patient partners are improving care, advancing research, and supporting you, our communities, and one another. These meetings are also a space for transparency and conversation, highlighting our progress and achievements, as well as discussing challenges and opportunities. Once again, I want to thank you to say thank you to everyone who continues to join these sessions, to stay engaged with the work we're doing. Your involvement helps shape these conversations and keeps us focused on what matters most. For our February meeting, I recognize Black History Month. This is an important time to honor the histories, contributions, and lived experience of Black individuals and communities, and to reaffirm our commitment to improving care experiences and health outcomes for Black patients, families, and communities. Throughout February, we've been celebrating Black History Month by hosting a variety of engaging events that honor the contribution of Black Canadians to healthcare and society. A highlight for tomorrow, mark your time for over lunch hour. Earlier this month, we partnered with Yaya's Kitchen to host a cultural lunch at Victorian Children's Hospital. It featured a traditional menu and dishes from a variety of African countries. And the great news is, if you missed that event, Yaya's Kitchen is back tomorrow from 11:30 to 1:30 for another cultural lunch in the University Hospital cafeteria. Proceeds from both lunches will be donated towards Type Diabetes, a nonprofit organization focused on culturally relevant education and food literacy to help equity-denied communities prevent and manage diabetes. If you missed the Black History Month vendor fair at Children's and Victoria Hospitals, you also have another opportunity. February 26th, we'll be hosting yet again at University Hospital an opportunity to highlight and celebrate local Black-owned businesses and cultural artisans. These events are open to patients and visitors, so I encourage you to check them out if you're in our hospitals that day. I'm incredibly proud to highlight that the work we're continuing to advance further Black health equity and tackle racism in our healthcare system includes the opportunity that I had back in June with many of our colleagues here at LHSC to meet with African, Caribbean, and Black community members. Their storytelling and lived experiences enabled me to learn more about the systemic barriers and inequities that can affect how our Black health community members experience the care that we deliver here. To support improvements in experience, LHSC has implemented the Black Health Navigator role here at LHSC. I'm proud to highlight the work of Sushani Brooks, who serves in this role. She works closely with patients and families to guide them through appointments, explain care options, and advocate alongside them during conversations with our care teams. Often, Sushani in the room provides immediate reassurance. Patients feel safer, more confident, and empowered to participate in their care. Her work also helps our care team members better understand cultural needs of Black patients, builds trust, and creates smoother, more respectful care experiences for everyone. The Black Health Navigator role is a real example of LHSC's community commitment to equity, culturally safe care, and making sure every patient feels valued and supported. Our learning and intentional action will continue. Over this past year, our adult eating disorders has gone through a significant transformation, and the results are already making a palpable difference for patients. In 2024, we had more than 300 people waiting for care, and by November of 2025, that number dropped to 31. That didn't happen by accident. It came from taking a hard look at our model of care and asking whether it was truly meeting the needs of the people we serve. The team shifted to an outpatient-focused approach and reinvested resources into expanding staffing, strengthening supports, and allowing us to see more patients, provide more timely assessments, and deliver care in ways that better fit the people's daily lives. This work reflects what we're trying to do across LHSC. Listen to our patients, listen to our staff, be honest about what is working and what isn't working as well as it could, and then make meaningful changes that improve access and outcomes. This care supports patients in their everyday lives and long-term recovery. The outpatient program provides therapy, medical support, nutritional guidance, and education for patients with eating disorders. Starting just last month, January of 2026, the service introduced 5 psychoeducational groups covering coping skills, nutrition, handling emotions, and tolerating uncertainty. Virtual meal supports are also offered Monday through Thursday, and these help patients practice eating regularly in their own environments. Fridays are left open for patients to experience these things and apply their skills on their own. This model helps patients reinforce important skills applications in the spaces of their lives. They stay connected to work, to school, or family while learning to apply strategies that support their recovery. Behind these programs and these numbers are the experiences of patients themselves, and their stories show real impact of these changes. Christopher first came to the program when he was 18 after being diagnosed with anorexia nervosa, which is a serious eating disorder characterized by an intense fear of gaining weight and a distorted body image that leads to severe food restriction and significant weight loss. After being in 7 years in recovery, he found that his symptoms were still present. Through re-entry, the adult eating disorder services, he received individual therapy, education, and relapse prevention planning. He learned new strategies to manage his eating disorder, and he practices self-therapy. Since leaving the program, Christopher continues to use these tools, adjust his social media, and apply what he's learned in daily life. He's also seen the program implement important feedback from himself, including creating a more queer-friendly space. Christopher describes his experience as helpful and empowering and supportive to his ongoing recovery. Christopher's story is a powerful reminder of why our work matters. It's about supporting patients every day, helping them build skills and tools to manage their health and thrive. At the same time, we're committed to advancing care for patients across all areas of health, and that is where our research comes in. I'm proud to share that our scientists at London Health Science Research Institute, or LHSCRI, have received over $3 million in new funding from the Canadian Institutes of Health Research. These grants will support studies aimed at improving dialysis care, stroke prevention, pediatric anxiety treatment, as well as knee reconstruction outcomes. This funding highlights the incredible talent we have here at LHSC and LHSC at RI, and the impact our research can have, not just for our patients, but for people across the province, the country, and the world. Now, as we move into presentations, I'm pleased to be joined by Dr. David Stephen, Department Head for Clinical Neurological Sciences and Interim Chair, Medical Advisory Committee, as we deliver our report to the community. Today, Dr. Stephen and I will share a brief snapshot of what we're seeing across the hospital system this winter, highlight how LHSC is improving care through research, collaboration, and close with a great story about how our community is improving comfort and engagement for patients. Our test positivity for influenza and COVID-19 is low, and our ED visits related to influenza-like illnesses have significantly reduced. Ongoing circulation of multiple respiratory viruses is still resulting in hospitalizations, particularly COVID and RSV, but in volumes well lower than our peak respiratory surge season, which came at the end of December and early January. While respiratory virus admissions are low, we are still seeing other seasonal illnesses. We are seeing some delayed medical care, stress and mental health factors, as well as accidents and injuries that continue to bring our community members in seeking care in the winter months. This ongoing demand for healthcare services continues to drive high hospital admissions and can result in longer wait times, particularly in our emergency departments and across our inpatient units. Know that our committed hospital teams continue to manage through these busy times with a focus on patient care needs. What can you do to help? Helping prevent the spread of illness matters. Simple actions continue to make a difference. Please consider staying home when you're sick, practice good hand hygiene, really good washing of hands, and keep your vaccinations up to date to help reduce transmission and protect those who are most vulnerable. If you happen to be 75 or older, please consider discussing the RSV vaccine with your healthcare provider. Vaccines are the most effective way to prevent serious illness. In addition to those small practical actions that help protect you and your family, as well as your community and our staff teams, if you need to go out well and well, please consider wearing a mask in crowded or clinical spaces, and try to improve the indoor airflow when you can. Open doors or windows for short periods of time and refresh that air inside. Got a research update here in London. You may remember earlier updates where we talked about microbiome research underway here in London, including the development of fecal microbiota transplant capsules, sometimes referred to more informally as poop pills. This work has involved our patients from our own region participating in early clinical trials, helping move this research forward while navigating their own cancer treatment journeys. And now we're beginning to see the next chapter of that work emerge through new international research findings. New studies recently published in Nature Medicine are now showing promising clinical results that could reshape how some cancers are treated. Researchers from Lawson Research Institute and LHSCRI, working alongside national collaborators, found that fecal microbiota transplants may significantly reduce toxic side effects of immunotherapy for patients with advanced kidney cancer. As many of you may know, while immunotherapy can be life-saving, the side effects can be severe enough that some patients must stop treatment early. The study results suggest these microbiome therapies could help patients tolerate treatment longer, which may directly impact survival and quality of life. Additional studies involving patients with lung cancer and melanoma showed a substantial higher response rate to immunotherapy when combined with these, when compared to immunotherapy alone. What makes this work especially meaningful is capsule technology itself was developed right here in London and tested through clinical trials at the Verspeten Family Cancer Centre. What a strong example of translational research moving directly from the laboratory into patient care and reinforces London's growing reputation as a global leader in microbiome innovation and cancer research. Behind the science, these advancements are driven by intentional and radical curiosity, courage, and tenacity, as well as collaboration across institutions, and importantly, by patients who participate in our clinical trials, helping shape the future of cancer care for people locally and around the world. I'll now turn it over to Dr. Stephen for updates on important collaborations and community donation work.
Thank you, Deborah. So I have the privilege of giving you an update on some of our community-based partnerships. So the first thing is improving access to care through Indigenous-led collaboration and partnering with Indigenous health organizations to bring screening and education into trusted community spaces, focusing on culturally safe care and early detection. So LHSC clinicians and partners are working alongside additional Indigenous health organizations and community leaders to bring screening and education directly into trusted community spaces. So for example, cervical cancer screening and education are being delivered through partnerships with Indigenous health partners and the Southwest Regional Cancer Program, focusing on culturally safe and trauma-informed approaches. Education always comes first, allowing participants to ask questions and make informed decisions about screening. Similarly, LHSC's renal program hosted its first community renal screening clinic in Oneida Nation of the Thames, providing early detection, health education, and connections to care. These initiatives focus on meeting people where they are and removing barriers such as transportation challenges and limited access to primary care. So also, there's other examples of expanded community-based screening. So in addition to delivering care in community spaces, teams are helping train nurses, midwives, and nurse practitioners to provide screening locally, expanding access beyond hospital settings. When screening can be done by providers people already know and trust, it helps remove practical barriers and makes participation easier. Community feedback has already been very positive, with participants returning for future events and encouraging others to attend. These partnerships have helped strengthen access to screening and supporting earlier detection and follow-up care. And lastly, community donations help enhance care, and volunteer-made items such as fidget items and twiddle muffs have donated. We have had almost 250 of these items donated, which are sensory tools to support patients at risk of decline and improves comfort and engagement during stays. Over the last 3 years, LHSC has received more than 250 such items made by the Huron Fidget Makers, a dedicated volunteer group from Southwestern Ontario. Recreational therapists use them to help prevent functional decline and reduce anxiety, particularly for patients experiencing confusion or long hospital stays. Each item is thoughtfully designed with different textures and activities to support individual patient needs. This is a meaningful example of community partnerships supporting whole person care and enhancing the patient experience in small but important ways. So I'd like to turn this back to Deborah Wiseman and Aneshta Campos for the next update.
Thanks, Dr. Stephen. As LHSC's corporate nurse executive, I'm excited to share something the public rarely sees, and that is how Nursing Practice Excellence and Innovation, or NPEI, supports nurses and other care team members at LHSC, and how that support directly and positively impacts the care our community receives. This team supports the people who support you. Our job in nursing practice is to make sure every nurse at LHSC, whether new or highly experienced, has what they need to deliver safe, high-quality, compassionate care. We build education, we implement best practices, we mentor teams, and we improve nursing and team confidence in an environment that is constantly changing. The benefit our team delivers includes improved patient care, improved safety, enhanced professional networks, improved efficiency, and a supportive work environment. Every improvement we make to nursing practice helps improve the experience and outcomes for patients and our families. I'll hand it over now to Aneshta Campos, our Interim Director of NPEI, who will tell you more about this exciting team. Anesh, over to you.
Thank you very much, Deborah. Good afternoon, everyone. I want to take you through our nurse practitioners. You may, as part of the community, you may have been able to see one of our nurse practitioners at LHSC. They're highly trained, advanced practice nurses who assess, diagnose, treat and prescribe, and manage care for patients with complex medical needs. They work both independently and collaboratively, and some programs may even serve as the most responsible provider. You'll see nurse practitioners support some of LHSC's most specialized areas, including neurosurgery, oncology, renal transplant, and women's health. Where patients often require intensive coordinated care, their advanced clinical skills help streamline treatment, reduce delays, and enhance patient safety and experience. Beyond direct care, there are nurse practitioner practice leads. They contribute to the education, quality improvement, and research. They help design programs, improve access, reduce wait times, and guide best practices across our organization. Their leadership enhances both patient outcomes and the overall care system at LHSC. We also have a robust group of clinical educators. They are the backbone of ongoing learning at LHSC. They help nurses adapt when equipment, policies, or technologies change. They ensure teams are ready for accreditation and safety standards. And they are a trusted resource when teams face new or unfamiliar situations and provide that at-the-elbow support that nurses really enjoy getting that support. Their work gives nurses the confidence they need to provide safe, effective care, ensuring every nurse stays current and confident in providing the best possible care based on the most recent evidence. We also have nursing practice consultants. They are practice experts. They help solve complex issues, build nursing guidelines, improve workflows, and support safe decision-making alongside our programs. If a nurse wonders, what is the safest way to do this? This team helps ensure the answer is clear, evidence-based, up-to-date, and consistent across all areas of LHSC. These are the nursing practice experts. They work closely with clinical programs, guiding complex nursing practice decisions according to the most up-to-date policies. The professional practice consultant, working with other members of the nursing professional scholarly practice team, is responsible for the development, monitoring, and evaluation of evolving standards of nursing practice within an interdisciplinary care model. This role also collaborates with leadership and professional staff to ensure the integration of nursing practice standards and program design, resource planning, and allocation in the delivery of patient-centered care. In considering the development of our nurses, when new nurses or nursing students join LHSC, they don't start alone. Nursing practice excellence and innovation provides simulation training, hands-on practice, guided scenarios, and mentorship. These programs make sure every nurse who steps onto a unit is prepared, supported, and ready to provide safe care for our community. Starting a nursing career can be overwhelming. That's why we created a structured program, our New Nurse Development Program, to help new nurses build confidence, sharpen their skills, and feel supported during their first year and beyond. This investment in new nurses strengthens care across the hospital. This ensures every nurse who cares for you and your loved one has been prepared and ready. Mentorship is really important across LHSC. Experienced nurses are dedicated to mentoring and supporting new nursing graduates and nurses transitioning into new clinical areas that they may not be familiar with. The Clinical Scholar Program is funded by Ontario Health, and it plays a crucial role in strengthening our nursing workforce. This funding allows experienced nurses to step into dedicated mentorship roles. Clinical scholars work directly beside nurses at the bedside, helping them build confidence, apply skills safely, and adapt to the fast-paced hospital environments. This hands-on guidance helps nurses feel supported from day one and reduces the stress that often comes with starting or changing roles. The impact is clear. Better nurses, stronger teams, improved patient safety, and more consistent care across LHSC. We're grateful for Ontario Health's investment. It truly helps create a more confident, resilient nursing workforce for our community. We're also very proud of the Betty Project, which is an initiative that stands for Bringing Education Technology to You. It's sponsored by RBC, which we're very grateful for. It supports interprofessional skill development in clinical areas through simulation, and it really helps our nurses and interprofessional teams practice different scenarios that for them to be able to ensure their comfort level once those scenarios arise in real life. And finally, in many ways, nursing professional excellence and innovation is invisible, and that's how we know we're doing our job. The photo you see on this slide highlights winners of our 2025 Nursing Excellence Awards. This and other recognition events really honor the work that drives improved safety, advances quality and innovation, and supports excellence in the care we deliver. When nurses are confident, informed, and supported, patients feel it. Families feel it, and our community feels it. Thank you for the opportunity to share the work we do behind the scenes to support excellence in nursing practice at LHSC. And now I'll introduce Dr. Adam Duclos, Integrated VP Medical and Academic Affairs and Emergency Physician at LHSC and St. Joseph's Health.
Thanks so much, Anesh, and thank you for having me today. It's my pleasure. And as Anesh mentioned, I have the privilege of being the Vice President of Medical and Academic Affairs for our 2 hospitals in London and a practicing emerg doc at St. Joe's Urgent Care and the emergency departments of London Health Sciences Center. Today, I'm going to go through some advice, I'll call it, on when you should choose the urgent care center versus when you should choose an emergency department here in our hospitals. We see a lot of people every year here at LHSC and St. Joe's, in fact, we see approximately 250,000 unplanned visits between the 2 hospitals. And we work very hard to ensure you're seen as quickly as possible. And it's not just the physicians, it's the nurses, the emerg department techs, and our administrative professionals that help ensure that you get seen quickly, but more importantly, of a highest quality care as possible. So what is the difference between an urgent care center and an emergency department? In terms of the urgent care center, where we see about 51,000 people a year, the next few slides will go through sort of some technical differences as well as some patient differences. But an urgent care center specifically does not receive ambulances. If you see an ambulance outside of St. Joe's Urgent Care Center, it's almost certainly picking up a patient to take over to LHSC because that patient exceeded the scope of care that's available at St. Joe's and may have needed to be admitted to hospital at LHSC. There are some occasions where the urgent care center does receive patients from other hospitals for specific services, like urology or plastic surgery or orthopedic surgery in the hand and upper limb. But for the most part, ambulances there would be leaving with patients to take them to LHSC. So most patients that come to urgent care but need to be admitted would end up going over to LHSC. There's the same group of providers, though, in terms of physicians, work at the 2 hospitals. So one week you may see myself or other emergency physicians at the UH Emerge, and the next week you might see us in urgent care, or even the next day. In terms of our nursing staff and other professionals, we have lots of staff that work in both places, and we have some staff that will spend a few years of their career in Emerge and then go to urgent care or vice versa. So lots of family type environment between the 2 hospitals. The diagnostics at urgent care, and we're talking specifically the St. Joe's Urgent Care rather than the other urgent care in the city that's not hospital affiliated, has a fairly significant diagnostic capabilities with CT scan, and we can, at times bring people back for MRIs as well. But we don't have as ready access to some of the more advanced imaging as we would in the emergency department. Lastly, one of the things that distinguishes an urgent care center is we have an opening and a closing time. So urgent care center in the city opens at 8 o'clock every morning, and the closing time depends on the day of the week, and depends on the day of the week and the volume of patients that we need to see. Now, what is the difference between that and an emergency department?
Sorry, everyone. I think we're just having a technical difficulty with Adam. One moment. All right, unfortunately, we had a technical difficulty there. I'm going to just ask Shannon Meyer, our VP of Children's Hospital, if she wouldn't mind going into the next presentation, and we'll update with Adam shortly.
Meyer, I'm the Vice President of Children's Hospital, Women's Care Quality Risk, and Pharmacy, and I'm delighted to participate in today's community update. We are extremely proud of the gender services we provide here at Children's Hospital, care that is grounded in compassion, evidence, and partnership with children, youth, their supports, and families. Today, I have the honor of introducing Raj Souza, our Director of Pediatrics, Acute Oncology, Inpatient Outpatient Services, and Minor Procedure Room, alongside Dr. Stein, our Division Head of Pediatric Endocrinology, whose leadership and expertise are central to this work. They are going to share with you an overview and some insights into how our team supports children and youth with respect to this life-changing care. Over to you, Raj and Dr. Stein.
Thank you, Shannon. Good afternoon, everyone. I would like to start by talking about establishment of Gender Pathway Clinic, a service that has become incredibly important for children and youth in the region. We recognized there were significant gaps in access to coordinated, specialized care. Families were often navigating a complex system without any clear pathway or consistent supports. In response, 4 acute care children's hospitals, including Children's Hospital, Linden Health Sciences Center, Hamilton Health Sciences Center, Sick Kids, and CHEO, came together to put forward a joint proposal focused on improving access, consistency, and overall quality of care for this population. We later received confirmation of funding to establish this clinic, an important milestone in advancing equitable and compassionate care. Since launching, the clinic has strengthened care coordination and supporting patients and families through complex journey, including social and medical transition. This work really demonstrates what can happen when organizations collaborate with a shared commitment to meeting the evolving needs of the communities we serve. A key strength of clinic has been its multidisciplinary model. The team includes physicians, nurse practitioners, social work, psychotherapists, and peer mentors who work collaboratively to support each child, youth, and family. Since launching, the clinic has provided families with a single supportive entry point into what can otherwise feel like a complex and overwhelming system. We're very proud of this clinic. Over to Dr. Stein.
Thank you, and it's a pleasure to be able to share what we're doing in our Gender Pathways service at Children's Hospital. As I start, I think it's important to just get a grounding in some definitions that can often get confused and that we use regularly with our clinic and talking with our patients and in educating other stakeholders. And so, when we talk about sex, we're talking about a person's biological characteristics, their chromosomes, their gonads, the genitals, and typically we think about the male sex and the female sex. We recognize that sometimes babies are born with some abnormalities where sometimes it might be difficult to differentiate male and female, and we call those disorders of sexual development, and that's a different topic. When we talk about gender, it's an individual's attitudes, their feelings and behaviors that can be associated with being male or female. And our gender identity is how we express that. And we typically think about a gender identity, somebody whose gender matches their sex assigned at birth as being cisgender, or if their gender is opposite from what their sex assigned at birth was, we talk about that as being transgender. And this is all different from sexual orientation, which is who somebody is attracted to. And typically we think about terms like heterosexual or gay or lesbian or bisexual. We recognize, though, that the gender spectrum is probably more complex than that. And certainly we talk about the masculine umbrella where individuals identify as cis male, where their sex assigned at birth matches their gender, or trans male, where their sex assigned at birth does not match their gender identity. And the same on the feminine umbrella with cis women or trans women. But we recognize that there are a lot of individuals that don't identify in either of these areas and may identify as gender nonconforming, gender fluid, two-spirit, or maybe even agender. When we look at how common gender congruence is, we see that it's quite common. The Canadian census data from a few years ago showed that about 1 in 300 individuals identify as transgender or non-binary. The majority of these individuals were younger, and we suspect that this is probably an underrepresentation. There's some pediatric data from high school surveys that show that 1 to 4% of adolescents report their gender identity different from that's assigned at birth. So this is common. It's common and it's important. We know that transgender youth are at higher risk for adverse health outcomes, depression, anxiety, self-harm, suicide. And we know that if we can provide positive gender affirming care, we can lower that risk. And that's providing affirming experiences at home, in schools, with extracurriculars, and certainly in the healthcare environment. And the earlier that individuals can access this gender affirming care, these environments, the better their mental health outcomes are. This graph sort of describes that. On the blue side, when we look at lifetime suicide attempt, when you look at the general population of Ontarians, 3.8% at some point in their life will have a suicide attempt. For trans Ontarians, it's more than 10 times that rate. 46%, almost half, will have a suicide attempt. But if you go onto those red bars, when you put that individual in a supportive environment, the risk comes down to that of the general population at 4%. So providing supportive environments, positive gender affirming care really makes a difference in the lives of these individuals. Our clinic follows clinical practice guidelines in providing care. WPATH, which is the World Professional Association for Transgender Health, is probably the most well-known guideline, and that's the guideline that most Canadian centers will use. The Endocrine Society guidelines are very similar to their North American guidelines, and both of these guidelines are supported and endorsed by the Canadian Pediatric Society. And essentially, when we're meeting patients, you know, at first, and a big part of what we do is getting to know them, getting to understand their gender journey, their gender experiences. And we're looking for, you know, their descriptions of, you know, their feelings on their gender and how well it matches or doesn't match with their sex assigned at birth. If their feelings about their gender leads to a desire to transition and be accepted as a person of their experienced gender. Do they describe having a strong dislike for their sexual anatomy or anxiety about anticipated pubertal changes, and a desire for their sexual characteristics to match their experienced gender? And then for younger children, we'll look at their make-believe play, their toys, their activities, and are those typical of their experienced gender? But in general, we're looking for, you know, insistence. Is this an insistent gender identity? Are they consistent with their gender identity? And are they persistent with the goals that they have for their care moving forward? I'll turn it back over to Raj. And you're muted, Raj.
This slide highlights the growing need and difference this clinic is making. We currently have about 270 patients. That's a lot for our clinic, but demands continue to grow, which reinforces the importance of sustained support. All of our patients are linked with medical practitioners and mental health support. The multidisciplinary model is improving patient well-being and patient experience. Our clinic is serving children and youth ages 7 to 18, with majority being teenagers. Seeing patients across this age range reinforces the importance of a family-centered multidisciplinary approach and making sure supports are developmentally appropriate. Over to you, Dr. Smith.
Thank you. When we meet patients and families, certainly there are a lot of steps and a lot of interactions that they're going to have with our team. The big part of what we do is the social supports, the mental health supports, the counseling supports, working with patients, working with their caregivers to understand their journey, to help them get connected with school resources, with community resources, with peers. For those individuals where it's appropriate, we'd start talking about medical transition using puberty blockers, other hormone therapies to help support their gender transition. And then again, when it's appropriate, we will have discussions around fertility preservation and discussions around the process for top and bottom surgery for those who are interested in learning more about that and for those where it's relevant. We're very proud about our clinic. The Gender Pathway Service is the only multidisciplinary clinic in Southwestern Ontario that provides this kind of multidisciplinary gender-affirming care to children and adolescents. We're establishing strong community partnerships. London Community Health Centre we're partnered with. We're partnered with Youth Opportunities Unlimited, and we've got some links and connections with Windsor's Trans Wellness Hub as well. We're also involved in the development of the Ontario Health Quality Standards for Gender Care, which will be coming out soon. And we're certainly do a lot of work and a lot of education at SCULIC and at the Arthur Labatt Family School of Nursing. So thank you very much for the opportunity to share what we're doing in Gender Pathway Service. We're very proud of the work that we're involved with.
Thank you both. I am now going to invite Dr. Adam Duclos back to the update.
Thanks so much, Shannon, and I apologize to my colleagues as well as to the audience for the technical glitch that I had. My computer restarted out of the blue. So here we are. For those of you that were watching when my computer blacked out, I had spent a couple minutes talking about what an urgent care center is, in that it doesn't receive ambulances and has an opening and closing time, and we don't tend to admit patients to a hospital, to St. Joe's from the urgent care center in London. We send them over to LHSC to be admitted. So what is an emergency department? Well, many of you know, and it's almost never a good day when you come to the emergency department as a patient, but hopefully we can help make it the best one possible for the circumstances you're in. Our emergency departments, there's 3 of them at LHSC, the Victoria Hospital, Children's Hospital, Emerge, which is located at Victoria, and University Hospital. All 3 are open around the clock, 24/7, 365. With a full suite of diagnostics. Everything you can think of are available in our healthcare facilities here in London. We also receive patients not only from London proper via ambulance or walk-in or sort of taxi cab. We do receive patients directly from the community through our EMS partners for specific things like trauma, where they might bypass a local hospital, or similarly, if someone's having a specific like a heart attack or a potential stroke, they may bypass their local hospital and come to London for the specialty care that we provide here. The emergency departments also receive patients that have been seen in another emergency department but require the type of care, specialized care provided at LHSC. So lots of different types of patients come to the emergency department, and pretty much, I'm very proud of the team that works in the emergency department, for whether it's the physicians or the nurses or everyone that's essential. We're ready for anything at any given time. So the next thing we wanted to talk about was to give some practical advice as to when you would choose the urgent care center versus the emergency department. So urgent care centers in general tend to treat minor illnesses, coughs, sprains, or maybe something you think is a sprain but turns out to be a minor break or fracture. Whereas, cuts, needing stitches, illnesses that cannot wait for a family doctor. So we are fortunate that there's a huge drive in the province to create more family physicians and to have better access to primary care, but we still suffer in London from a large number of people that don't have a family doctor. For those of you that do have a family doctor, if something can wait and you can get access, that's still your best option. I would prefer, the system would prefer that you see your family doctor if possible. But if it can't wait or you can't get access to your family doctor, don't have one, the urgent care center is a great place for those types of things. Whereas the emergency department, something like a chest pain or severe abdominal pain, signs of a stroke or a mini stroke, those should really be seen in the emergency department, where we have advanced imaging, can triage you appropriately, and have you seen by the right provider in the right place. Serious mental health concerns where you might need to be admitted to hospital for risk of self-harm or hallucinations, delusions, those types of things you'd want to be seen at the emergency department, or pregnancy-related concerns. Specifically, we would hope you would make your way to Victoria Hospital, where we have the expertise of our obstetricians and gynecologists. One example I didn't bring up that is very appropriate for urgent care center is eye problems. St. Joe's we're lucky in London, St. Joseph's has the IVI Institute, and we see a lot of patients with eye concerns at the urgent care center, and can, when necessary, just send them right upstairs to see the ophthalmologist fairly quickly without transferring from the emergency department. So we're proud of the system we have in London here and the access that we're able to provide within the constrained resources. And I'm also happy to be here today to help you navigate that system, because it's not always as easy as one might think. On the next slide, we have some sort of concrete examples of what you might choose. So a child with a fever or rash, urgent care center. But if you have a child with a fever or rash and they're lethargic or not eating or drinking at all, and may need IV rehydration or blood work, you probably want to go to the Children's Hospital emergency department. Crushing chest pain, emergency department. Trouble speaking, maybe a stroke, emergency department. Just to give you a better idea of what you might choose when you're fortunate enough to have a potential illness that needs to be seen quickly or acutely by emergency medicine providers. Lastly, I wanted to highlight the great work that happens between our urgent care center and emergency departments. I mentioned in the first part of this broken up presentation that we work as a team, and we send patients from the urgent care center over to emerge when they need to be admitted. And that requires communication between both the providers as well as the administrators to make that happen. And even on occasion, if someone has, say, an ocular emergency, they will get sent from LHSC over to St. Joe's as well. So I'm very proud of the team, as I said, and the collaboration between our two hospitals in the city. And I think now I am handing it back to our Vice President of Children. Oh, we've got my apologies, the addresses, locations, and the hours for the urgent care center on the last slide for reference. And that's available on the websites at all times. And you can even see wait times on the websites as well. So thanks again for the opportunity to be here. I'm going to toss it back to Shannon Meyer, our VP for Children's and Women's and Quality. Thanks, Shannon.
Thanks so much, Adam. Excited to talk about our next program. Two of LHSC's most read stories in 2025 were regarding women's care. We know that a large majority of our audience on social media are women, and we want to bring more attention now and over the coming months to what women's care is about, and to support women's health. Knowing that has been underrepresented historically, we're intentionally raising the profile of obstetrics and gynecology services at LHSC. We want women in our community and catchment to know where and when to access care across their lifespan. So please welcome Dr. Barry McMillan, Division Head of Obstetrics and Gynecology, and Amanda Williams, our Director of Women's Care and Regional Genetics Program, to tell you more about important services available here.
Thank you, Shannon, and good afternoon, everyone. I'm very happy to be here today with Dr. McMillan, who is the physician lead for the Department of Gynecology. Dr. McMillan, it's been an exciting time for the women's program over the last few years as it relates to gynecology, with some new options for patients. And I'm grateful for this opportunity to be able to ask you some questions about these new initiatives and to share them with our community. So late in 2024, the Gynecology Minor Procedure Room was launched, and it runs 1 day a week. Can you share how it was determined that the women's program needed a minor procedure room, and what procedures can be done in that setting?
Thank you, Amanda. It is common for patients seen in the women's outpatient clinic to have problems that require minor procedural interventions for diagnosis or treatment. Some typical examples would include endometrial biopsy to assess pre- and postmenopausal abnormal bleeding, as well as other tissue biopsies of the genital tract or perineal skin. Although many of these patients biopsies can be done in the clinic itself with little more than a local anesthetic. Some patients may need additional anesthetic or pain management options. Occasionally, an operative procedure with use of a general anesthetic may be required. The minor procedure room allows an alternative option in the form of conscious sedation, circumventing the potential trip to the operating room and improving the patient experience generally. Beyond biopsy, some patients expressing anxiety around having a pelvic examination or pap smear done, possibly due to previous trauma or bad experience with such an examination, also have another option without needing to proceed to an examination under anesthesia in the main OR. The use of conscious sedation for supervised examination with their gynecologist, the procedural room nurse, and any other designated support person can help facilitate completion of these important exams in an environment focused on improving their patient experience.
Thank you. And what are some other benefits of having a minor procedure room as an option for patients for the procedures that you mentioned?
Yeah, besides the improvement in pain that may be experienced with the procedures as mentioned, there is the potential avoidance of arranging a minor surgery in the operating room. Although use of the full general anesthetic may still be the best option for some of these interventions, use of the minor procedure room should obviate the much longer and more labor-intensive process of booking a procedure through the main operating room. Patients managed with conscious sedation would usually recover in about an hour and be leaving the hospital. Whereas if you go through the operating room, there's about a 2-hour pre-procedure care through the surgical daycare unit before the operation, then a 1 or 2 hour procedure in the operating room, and then a couple of hours afterwards in recovery room, with all the inherent physician, nursing time, and equipment costs incurred by that pathway. To date, there's been about 168 patients managed to the minor procedure room, with the benefits ranging from that, personal patient convenience to more efficient use of valued hospital resources.
Thank you. One of the new clinics we also have established is the RACE Clinic, which stands for Rapid Access IUC and Implant Center of Excellence. Can you tell us a little about this clinic, please?
Sure, Amanda. Intrauterine contraceptive devices really service two important areas of gynecologic care. First, patients seeking a long-term effective form of contraception, and secondly, those seeking treatment for abnormal uterine bleeding. The RACE Clinic allows patients wanting an IUD for management of either of these problems timely and efficient access to device insertion. Referral to the clinics is often made by the patient's primary care physician, but there is a process of self-referral that's possibly used as well. The focus is on getting the patient into the clinic quickly to avoid long delays that would potentially lead to complications of an unwanted pregnancy or episodic emergency room visits for heavy uterine bleeding or treatment of possibly anemia. Similarly to the minor procedure room, the advantages of this clinic in terms of conscious sedation, additional pain control options are there as well. Again, all designed to improve the patient's experience around having an IUD inserted. Lastly, there's ultrasound guidance that's also available to facilitate accurate placement of the IUD in this clinic, and that's aimed at reducing potential complications related to malpositioning or uterine perforation that can occur with insertion. The clinic also has providers with clinical expertise for the insertion of the subdermal Nexplanon contraceptive implant. This again is another long-term form of contraception lasting 3 to 5 years that's similar to an IUD, but doesn't actually involve insertion through the genital tract.
Thank you. That's a significant impact to so many patients. And given the positive response to the minor procedure room, do you see an opportunity to add more procedures to the minor procedure room?
Yes, of course. We are hoping to see an expansion of the minor procedure room, both in terms of the dedicated days during the week that we can utilize it, as well as more procedures that will require some specialized equipment. Specifically, we're looking towards adding both diagnostic and therapeutic hysteroscopy procedures to the list of what we already do in this setting. Hysteroscopy does require capital equipment investment for reusable scopes and video equipment, along with hospital infrastructure support for equipment cleaning, reprocessing, sterilization, and maintenance. With therapeutic hysteroscopic procedures, examples would be removal of an endometrial polyp or submucous fibroid or potentially endometrial ablation. There would also be an individual case cost for disposable single-use devices. We are presently assessing the feasibility of this through an integrated programmatic business plan. The advantages from a patient experience standpoint and offsetting hospital operating costs, as well as potentially reducing wait lists, could be substantial, though, given the fact that our department does hundreds of such procedures per year in the main operating room.
Thank you for that information. And knowing that the fear of pain or discomfort sometimes has stopped people from accessing the care they need, having this dedicated space with a minor procedure room to deal with pain management options for patients is making a difference to so many people. Dr. McMillan, gynecology has subspecialties, and you are one of 3 urogynecologists that we have at LHSC. What is the prevalence of incontinence in women, and what does the Women's Care Program offer patients who experience urinary incontinence?
Thanks, Amanda, for allowing me to put a plug in for my own subspecialty. Female urinary incontinence is a big problem. You could describe it, or people may understand it as uncontrolled bladder leaking. It is highly prevalent or common and often quite underreported in the population. It's estimated that between 25 and 60% of adult women experience uncontrolled incontinence, depending on the exact definition that's used. The number can climb to over 75% of women over the age of 65. Complicating this picture further is the paucity of caregivers either interested or skilled in managing this problem. Many women simply think that urinary incontinence is a normal part of aging and don't seek out care until the condition becomes quite troublesome. At that point, they are often dismayed at being placed on wait lists that range from 2 to 3 years to access members of my urogynecology specialty in Canada. Knowing these problems, we did establish the Continence Care Clinic, nursing care clinic, 8 to 9 years ago, following a generous donation from Shoppers Drug Mart. This clinic is managed by specially trained continence care nurses who assess, advise, and initiate basic care options for patients with urinary incontinence. The clinic is, of course, supervised by the physicians in our division, and some patients are triaged onto us for more advanced care if they have inappropriately been sent to that clinic. But many can be treated effectively without the need for a formal urogynecology consult. The clinic runs 1 day per week, and although scaling back for several years during the COVID-19 pandemic, we have seen over 650 patients and provided over 1,500 visits for biofeedback training and conservative patient education for incontinence. Truly, this is a success story within the Women's Care Program and will continue to be there as a valued service for the women and primary caregivers in the region. The last comment I'd like to make is that the Continence Care Program is likely to see an additional boost or expansion to patient care into the area of pessary and device management for prolapse and urinary incontinence. Our center has been provincially targeted by the Ministry of Health to receive funding directed towards pessary education and care for interested caregivers and patients. The PEACE program, Pessary Education and Access to Continence Expertise, will look towards creating an educational platform for interested medical and paramedical caregivers to be trained in providing proficient, timely, and cost-effective pessary care to patients throughout Ontario. The program is being developed presently as we hope to see formal funding support in the next few months. Truly exciting times. Thank you, Amanda.
Thanks, Dr. McMillan, for all the information you shared today. And yes, the PEACE project is definitely an innovative project with many facets to it that includes equity, increasing awareness related to incontinence, as well as providing educational opportunities for the community and healthcare providers. And as the project is in its early stages, there will be more to come on this project in the next few months. Thank you, everybody, for your time. And back to you, Deborah.
Thank you so much, Amanda and Dr. McMillan, for joining us today and for sharing more about the Women's Minor Procedure Room and all the advances that you are working on, both internally and externally, that will be valuable to our patients in the communities. Before we close, I want to remind everyone that we have a web form available for you to submit questions that can be answered in these meetings. You can find the link in the description on YouTube and on the Community Update meeting page of our website. We also have a QR code up on the screen right now for you to scan. It'll take you to the form to submit the questions. Since our January Community Update meeting, we've received a handful of questions that I'd like to take a few minutes to answer for you. The first question relates to the creation of the Yonka Family Pediatric Center of Excellence. Funding from the Yonka family donation has been instrumental in strengthening and advancing pediatric oncology, the program, by enabling meaningful improvements to how specialized care is delivered within the existing environment. The donation has supported the development of more coordinated, high-quality oncology model focused on clinical excellence, safety, and patient experience. So far, dedicated oncology patient rooms have been prioritized to provide a more consistent and supportive care environment for children and families. We've established a dedicated oncology pharmacy role, significantly enhancing medication safety, treatment coordination, and clinical support. In addition, a dedicated quality safety specialist role has been implemented to provide focused quality improvement, safety oversight, and ongoing program development. The Yonka family donation has further strengthened oncology research through targeted donor support, helping advance innovation and evidence-informed practice within the program. Together, these investments have had a tangible impact on specialization, safety, and quality of pediatric oncology care, ensuring that children and families benefit directly from the generosity of the Yonka family today. These donor-enabled advancements provide a strong foundation for the program's continued growth and sustainability, while longer-term planning for future system capability and capacity continues. The next question relates to ongoing work at LHSC that we're doing around our Community Advisory Committee and our organizational review. Over the last year, LHSC has been focused on strengthening our organization through meaningful structural improvement work. An independent, detailed organizational review examined our leadership, our governance, our finances, and our operations, and it resulted in 169 recommendations that we are implementing over the next 3 years through dedicated working groups across the hospital. Within weeks of the provincial supervision, LHSC also established the Community Advisory Committee in October of 2024. Following the launch of staff and public surveys in November 2024, this quickly was enabled to gather feedback and identify opportunities for improvement. This work is aligned with the Community Advisory Committee survey report and the action plan, and it's shaped by feedback of more than 4,000 staff, patients, and community members, and focused on priorities like communication, staffing, workload, patient access, training, our facilities, as well as community engagement. While so much of this work happens and continues to be happening quietly, it's about building a stronger foundation so our teams can continue to deliver the high-quality care our community relies on and expects of us, and we remain committed to sharing regular updates about this work as it moves forward. We were also asked about childcare at LHSC while parents are receiving treatments. We know that balancing family responsibilities while receiving care can be incredibly challenging, and we do recognize that childcare is an important concern for many patients and families. At this time, LHSC does not offer on-site childcare services for parents or caregivers attending their appointments or receiving care. Our final question that we received was from a patient about whether medical students or residents will be involved in their care. Patients can choose to refuse or request to not have medical students or residents involved in their care, and we will do our best to respect that choice. There's an important difference we'd like to share between students or residents observing for learning purposes and those actively providing care under supervision. For observations, patients can simply decline participation. When a student or resident is actually providing care, the doctor will explain who's involved and what that means. Medical residents, it's important to know, they're qualified doctors who've completed medical school and are training to become specialists. They're closely supervised by experienced physicians. And we benefit from being a teaching hospital with resident programs, ensuring safety and well-being and care decisions are reviewed. They provide a crucial role in the healthcare system as they gain experience and skill, and are essential for the overall quality of our healthcare provided, inclusive of that supervised physician support. Please know if you are a patient and you prefer not to have participating students or residents, the supervising physician will discuss what impact this might have on the care and will work with you to find the best approach, always keeping the patient's safety and treatment as the priority. This wraps up the question and answer segment of today's meeting. Thank you for submitting those questions. We truly appreciate your engagement and encourage you to continue submitting any questions you may have. They help us to ensure we're addressing the topics that most matter to you. I want to thank everybody for tuning in today. And to our media partners, please join us now for our media scrum. We look forward to addressing the questions you might have for us as well. Take care, everybody. Have a great day.